All right, we're starting this discussion talking about different conditions in association with hypertension. So first of all, a little background on hypertension. When a person has atherosclerosis or an atherosclerotic plaque, the blood going into their heart, kind of draw sort of what happens. So let's say this is just a blood vessel going into the heart. They get some plaque buildup here, and it decreases the amount of blood that can go into their heart. When this happens, the heart ends up thinking, wow, I don't have enough blood. Maybe I'm bleeding out, or something's going on wrong because I don't have enough blood getting to my heart. Maybe I was injured by a bear and I'm bleeding. Who knows? So the heart doesn't know, but it thinks, you know what I mean. Anyway, so it says, okay, I need more blood because I'm not getting enough blood to me. So what it does is it sends out some signals that go to different parts of the body, and like, for example, the kidneys, and it tells the kidneys to retain more water, okay, more fluid. And as a result of your kidneys holding on to more water, you end up getting really a lot of pressure inside of your blood vessels. And all this pressure kind of solves the problem. Okay, now we're getting more pressure to push more blood into the heart, but it also has a lot of bad side effects. See, the problem really wasn't that you didn't have enough blood, enough fluid getting here. The problem was that there was an atherosclerotic plaque that was kind of plugging the hole. It wasn't that there wasn't enough blood. So as a result, your blood pressure gets really high all over your body. You get edema, which is like swelling in your tissues. The blood pressure inside of the blood vessel itself is literally higher than the pressure out in the surrounding tissues, and so the fluid seeps out. And also it's really hard on your heart because your heart has to push really hard because there's all this pressure and stuff. It's like a really high pressure system. And so in reality, the compensation of your body that said, oh, I need to hold on to more fluids, was bad. It wasn't good, because that's not what the problem was. The problem wasn't that you didn't have enough fluids. The problem was that you had an atherosclerotic plaque, which can lead to like an angina, chest pain. So what are we going to do about this? Well, we need to go into this whole system here and tell the heart, or tell the body, to get rid of water, get rid of some fluid, get rid of some water, so that the hypertension goes away. But depending on other conditions that you have, like such as pregnancy, heart failure, or diabetes, you want to give different medications for this. So starting out, just ordinary hypertension. This person does not have diabetes, does not have heart failure, does not have pregnancy. This person just has primary hypertension. So what are you going to give them? Well, one of the first things you could give them is something called Thiazide Diuretic. A Thiazide Diuretic, for example, hydrochlorothiazide, which I'll write out here real quick. Hydrochlorothiazide. It's a big name. What does it do? It inhibits the sodium chlorine transporter. Sodium chlorine transporter. Okay, so essentially what's going on here is that on your distal convoluted tubule, so I'll explain this. So inside of your kidneys, I'm not going to go into a lot of depth because it's not the point of this lecture, just kind of review the drugs, but essentially inside of your kidneys you have this little tubular network, okay? And at different parts of this tubular network, your body puts ions into the tract that's leading to your urine, and it also removes ions out of the tract that's leading to urine. Not just ions, but other things too, molecules. And so what this does, what hydrochlorothiazide does, is it inhibits one of the kidney's little channels, little transporter that it has here, that moves sodium and chlorine as a transporter. And so it inhibits that transporter in the distal convoluted tubule. There's a proximal convoluted tubule, the loop of Henle, distal convoluted tubule, so it's back in the distal part. and inhibits that transporter, which increases the urinary potassium excretion. And because reabsorption is less efficient in the face of increased sodium delivery to the collecting duct. So essentially what's going on here, just what you need to know is that this hydrochlorothiazide has its effect in the distal convoluted tubule. Its effect is to inhibit sodium chlorine transporters, and the net result is that you pee more. Okay? Possible side effect though is hypokalemia and hyponatremia. Okay? Hypo means low, and kalemia is for potassium. Okay? So in other words, here's the way you can think about it. Water tends to follow ions. So if you are shutting down one of these little transporters that's putting the ions back into your body, it leaves them down inside of the little tract that goes to pee out stuff. And so essentially what's happening is all your ions stay in this tract, not all of them, but a lot of them stay in this tract, and so the water stays in the tract. And the water follows those ions, and you pee out those ions. You pee out your potassium, and you pee out your sodium. And so the result of this, the side effect, a bad side effect, is hypokalemia and hyponatremia. And so, but it's a diuretic. Diuretic means it makes you go pee. So it's a quick review. Hydrochlorothiazide is a diuretic, a thiazide diuretic that you give to people who have ordinary hypertension, and it makes them pee out more fluid instead of retaining the fluid, and with it pees out potassium and sodium, and it helps the hypertension go away and compensates for this problem that they're having. So that's the first thing you can do to give somebody who has primary hypertension. And this is called an essential hypertension. What else can you give a person? Well, you can give them an ACE inhibitor. Okay, when you think ACE inhibitor, what the heck is an ACE inhibitor? ACE inhibitor stands for angiotensin converting enzyme. Okay, so this is an angiotensin converting enzyme inhibitor. Let me explain how this works really quickly. It's really not that complicated. So you have this molecule called angiotensinogen. Angiotensinogen. And it doesn't really do anything. It's excreted from the liver. It doesn't do anything except, until it is altered by something called renin. Renin. So this comes from your liver and the angiotensinogen, and it is altered by renin, which turns it into, I put it down here, something called angiotensin 1. And angiotensin 1 isn't really the active one either. And angiotensin 1 is changed by angiotensin converting enzyme, which I believe comes from the lungs, if I remember correctly. Angiotensin converting enzyme, which is ACE, A-C-E, converts angiotensin 1 into something called angiotensin 2. Okay? Angiotensin 2. Angiotensin 2 is very active. It does lots of stuff. Particularly, angiotensin 2 goes into your blood vessels and tells them to tense down. Now let's think about this a little bit. Going back here, angiotensin, the molecule that comes from the liver, angiotensin, okay? Angiotensin is converted into angiotensin 1 by renin in the liver. So, in the kidneys, okay? So what happens here essentially is that your body detects, I'm not getting enough blood to my heart. And so your heart is going to send out these signals ultimately that result in renin going in and starting this process of your body acting as if you're bleeding out, as if you just got attacked by a wolf or something and blood's dripping out because you're not getting enough blood to your heart, and it says, we need more blood. That's what's occurring here, okay? That's what this whole thing is saying. So it tells your kidneys, send out the renin signal, and the renin signal is going to start cleaving these molecules that are going to create angiotensin 2. Angiotensin 2 is going to take your blood vessels and it's going to squeeze, it's going to make them tense. Angiotensin 2 squeezes them down, okay? That's good if you were actually bleeding out, because it means that you're going to get, this isn't full of water, but here's some water at the bottom, and let's say I want to get water up to this white mark, okay, because there's not enough blood getting to the heart, and it says, okay, we need to increase the tightness here, so it squeezes this down. There, look, now water's getting up to the white mark. So that's what it's thinking, is it's thinking that it's going to get water up to, or blood to the heart. But that's not the problem, though. This is all messed up because you had an atherosclerotic plaque. Okay, so what we need to do here, what this does, this angiotensin converting enzyme, what it does is it goes here, angiotensin converting enzyme inhibitor, ACE inhibitors, is it goes to this ACE and it shuts it down, okay? If that ACE is shut down, angiotensin converting enzyme is shut down, then angiotensin 1 is never going to turn into angiotensin 2. And if angiotensin 2 is not present, then your blood vessels will not squeeze down. The other effect of angiotensin 2 is that it triggers aldosterone release, okay? It essentially, or it ends up resulting in you having aldosterone. Aldosterone causes you to hold on to more fluids. So this is a great place to stop this. So what is an ACE? What are some examples of ACE? ACEs end in the suffix pril, like captopril, okay? Enalapril, ends in pril. So that's something that you give to a person with hypertension, is you want to shut this down. They have hypertension because their blood vessels are all tightened down, and you want to give them captopril to shut down the angiotensin converting enzyme, to inhibit it, and that way everything's not so tight, and so their blood pressure goes down. Okay, so that's the second thing you give them. Now, what else can you give them? You can also give them a calcium channel blocker. Okay, calcium channel blockers. There's a number of different examples. For example, verapamil or nifedipine. What these do, it's kind of complicated, but essentially the main idea here is both in the beating of your heart and also in the constriction of muscles. I guess I'd put it this way: all muscles use calcium to constrict. Okay, so if you block the calcium, then you're going to block the constriction, putting it really, really simply. So examples of calcium channel blockers are nifedipine and verapamil. Nifedipine, I don't remember how to spell it, and verapamil. There are some calcium channel blockers, okay? And they go in there, they block the calcium, and muscles, such as muscles in your smooth muscle, are going to not contract so heavily. It might also have effects in your heart too. Honestly, I don't know, which it just said on the thing, calcium channel blockers are indicated. I don't know if they're talking about the ones that are more for the heart effects or more for the vasculature effects. Didn't specify that. Next one, dihydropyridine, okay? Dihydropyridine is another example of a calcium channel blocker. So there it is. Okay, so now that was primary hypertension. See, I spelled that wrong. You know what I mean. Okay, so now let's move on to circumstances where things are a little changed. For example, what if the person has had a heart failure? In other words, their heart basically there wasn't enough blood and part of it died. It was stopping, or I don't know all the conditions that can be behind this, but okay, heart failure. So if a person has heart failure and they have hypertension, maybe it's that the hypertension was because of the heart failure because things are backed up. I'm not sure what all the conditions are, but similarly, you want to give them diuretics. You want to decrease the amount of fluid in their body. there are other I gave you an example of hydrochlorothiazide, but there are other diuretics. For example, there's one called Mannitol. Mannitol just makes you, basically, it goes in there and it sucks all the water to it. It doesn't get reabsorbed anywhere, and it just makes you pee a whole bunch. That's a diuretic. Another diuretic is acetazolamide. That's usually used for glaucoma, but that's another example of a diuretic. What this does is it inhibits carbonic anhydrase. Kind of complicated. One of the things that they're throwing around there are different forms of bicarbonate or carbonate, whatever, or carbon. And this is in the renal tubulars, or the renal tubules. And so acetazolamide essentially messes with some of the intermediate forms of this and results in you peeing out more bicarbonate, carbon dioxide, associated molecules, and the water follows those, and you pee those out. Another diuretic is one called furosemide, Furosemide, also known as Lasix. This one is a sodium, potassium, chlorine cotransporter inhibitor. Okay, so if you remember all the things, you remember there was the proximal convoluted tubule, there's the loop of Henle, the distal convoluted tubule. This one has its effect in in that little loop of Henle, there's like there's like a thick ascending limb and a descending limb, all these different things like that. But this one has its effect in the thick ascending limb of the loop of Henle. Okay, so on the thick ascending limb, which means it's the loop of Henle goes down and then it comes back up, and on the thick part of the ascension here, this is where it has its effect on the sodium, potassium, chlorine cotransporter. It inhibits that, and the result is ultimately, so what you need to know, that you pee out more fluids. And the danger with this, though, is hyperkalemia, because ultimately you end up peeing out too much potassium. Okay, so that's another diuretic. Usually this is used for cases where people have lots of edema. Remember, edema is where you get swelling in your tissues, usually your legs. Another diuretic is called spironolactone. Spironolactone is a competitive antagonist of aldosterone. So that would actually go more under aldosterone antagonists, more likely, but there it is. It's also known as a diuretic. So, okay. So that's the first thing here. You'd give people with heart failure and hypertension, is you'd give them these diuretics. The other thing you'd give them, again, same thing, are the ACE inhibitors. Oh, you know what I didn't mention? I accidentally failed to mention on the previous one something called ARBs. ARBs stands for Angiotensin 2 receptor blocker. Remember, angiotensin 2 was the really active molecule that bound to your blood vessels and caused them to clamp down. Okay, if you give somebody an angiotensin 2 receptor blocker, or an ARB, they usually end in sartan, such as I think it's candesartan was one of them. Oh goodness, I can't remember all the different names. Losartan. Anyway, I can't remember all the different names, but ends in sartan. You give them one of these sartan drugs, like losartan, angiotensin receptor blocker, and instead, so the person still has lots of angiotensin 2 in their system, but it can't get in the door. Somebody's blocking the door, so the losartan, or excuse me, so the angiotensin 2 can't go in and cause it to clamp down. So the result is vasodilation. Okay, now would decrease the tension, the hypertension. Okay, so you use the ARBs for this and this. Same thing also with heart failure is you use the ACE inhibitors. Remember, angiotensin converting enzyme. Also, you use something called beta blockers. Okay, but you want to be careful. You don't give them too much. You can give too high of a dose. So I don't know what the reason why you give beta blockers in the case of heart failure, but not in just primary or essential hypertension. But I'm going to make a guess here. I'm going to make an assumption. I know in the case of heart failure that your heart, your heart wasn't getting enough of what it needed, and your body wasn't getting enough oxygenated blood, and so your heart tried to compensate by beating really, really fast. Okay, and your heart's beating really fast. How long can your heart do that? Okay, like if I'm running a marathon, how long can you run sprinting before your heart just, oh, I can't take it anymore? You start getting really bad chest pain because your muscle cells, your cardiac myocytes are dying. Well, you need to slow the heart down. Okay, the heart thinks that it's maybe I'm not beating fast enough. I don't know what it's thinking. It doesn't really think, but it's reacting to something. But you need to slow it down, or else it's gonna die. It's gonna fail. So in the case of heart failure and hypertension, you give the person a beta blocker. There are beta 1 and beta 2 receptors, and the beta, I think it's the beta 1 receptors. Something binds to these beta 1 receptors. It causes increased chronotropy, which means the heart beats faster, and also increased inotropy, which means it beats harder as well, so harder and faster. So if you block that, the heart's going to be slower and not as hard, which means it's going to, instead of sprinting, it's going to be like walking, like just nice and easy, okay? So that makes sense to me why you would give a beta blocker in the case of heart failure. And these beta blockers end in olol, okay? A lot of these patterns, you're starting to see some patterns here. ACE inhibitors end in pril. ARBs end in sartan. So this is ACE inhibitor. This is ARBs. You notice that the now the beta blockers, they end in olol. Okay, so now you're kind of starting to see this pattern here. Trying to think of some examples of olol. I have some here. Can't remember all the names of these. I'm still learning this myself. Looks like I don't have any on hand. Sorry. Oh, labetalol. Labetalol is an example. Labetalol is a non-selective beta blocker. Okay, so that's an example of a beta blocker. Labetalol. Okay, so we're down here. Heart failure, you're going to give them a beta blocker. Makes sense. So you give them all the other stuff plus a beta blocker. Also, they mention here aldosterone antagonists. So one of the aldosterone antagonists that we mentioned earlier was spironolactone. Sometimes the trade name for it is aldactone, which is nice because alda has aldosterone kind of sound in it. So spironolactone, so an aldosterone antagonist. So aldosterone, I kind of try to think of aldosterone, and stone makes me think of minerals, and salt is a mineral. And so what aldosterone does is it has you retain sodium, salt. And when you retain the salt and the sodium, you retain water with it because the water follows the ions. So aldosterone antagonists essentially antagonize, or yeah, the opposite effect of that. Okay, that makes sense. So that's what you do in a person with heart failure and hypertension. However, there are some drugs you do not give people who have heart failure and hypertension. You do not give them verapamil. You do not give them diltiazem. You do not give them a high dose of beta blockers. So if their heart's failing and you give them too much beta blockers, it's going really fast and you give them too much, now their heart's already damaged. You don't want it to stop, or just barely beat at all. It still needs to do some beating here. So careful with your dose of beta blockers. Their heart still has to keep them alive, and it's already damaged, and so it's going to be running kind of weak anyway. So be careful. So verapamil. I'm trying to remember what verapamil is. Okay, verapamil is a calcium channel blocker. I've got my little notes down here to help me out. It's a calcium channel blocker. Let me pull up my card. And so it decreases heart rate and decreases inotropy. So it says that it slows the conduction of SA and AB nodes. So apparently, I'm guessing that maybe giving verapamil, this calcium channel blocker, maybe it's just too much. When a person with heart failure, maybe it would slow it down too much. I'm not sure, but you don't give them verapamil. And you also don't give them diltiazem. And I believe diltiazem is also a, where did I put my diltiazem? I think it is also one of those as well, but I can't remember off the top of my head. Yeah, I don't see it. Sorry. Let me look through these really quickly. Yep, don't have my diltiazem anywhere. Okay, so you have to look up diltiazem on your own. But you don't give that to a person with heart failure. And since I don't remember what the drug does, I can't tell you why not to take it, or why I would assume not to take it. Okay, so we talked about primary hypertension, or essential hypertension. We talked about heart failure with hypertension, and we talked about, now we're going to talk about diabetes with hypertension. So, person with diabetes, similar story here, okay? You want to give them ACE inhibitors, like captopril. You want to give them ARBs, angiotensin receptor blockers, like losartan. You want to give these people calcium channel blockers, okay, such as verapamil and nifedipine. But remember, you didn't give verapamil up here to these people with heart failure, so that's a difference, okay. So you give the diabetics verapamil and nifedipine, and I guess it's probably because their heart's fine, like their heart's not damaged necessarily. Maybe it is, but that's not the thing. They're not undergoing heart failure. They just have diabetes. So yeah, slow the heart down. I'm trying to think of another reason why you do that. I don't know if this is the reason, but this is some thought process that goes through my head. When a person has diabetes, there's all this sugar running through their blood vessels, and sugar binds to their arteries, the proteins and whatnot, and it's called a glycation, I think it's a glycation reaction, something like that. Anyway, it makes them really hard, and if your heart's beating too hard, maybe that could increase the likelihood of damage being associated there. I don't know, just a thought. Also thiazide diuretics. Remember we talked about hydrochlorothiazide? That was the one that had the effect on the distal convoluted tubule and blocked I think it was the sodium chlorine channels, and yeah, if I remember correctly. Maybe it's sodium potassium. I don't remember. And now also you'd use beta blockers, same as up here, such as anything that ends with olol, like labetalol. Okay, so now the last condition that we're going to talk, and you don't give people a high dose of beta blockers. I don't know why, but it says not to do that, who have diabetes. Okay, for a person who is pregnant with hypertension, you've got to realize when a woman becomes pregnant, her body is going to hold on to, I drew a picture, I'll explain in a minute to help you remember some stuff. A woman who becomes pregnant, their body holds on to more fluids. They need to have higher blood pressure to get blood to the baby, because it's not just blood for them, it's blood for them and the baby. And this results in varicose veins and hypertension sometimes. So when there's a pregnant woman who has some hypertension, but you need to be really careful what you give them, because some of the side effects of some of these drugs could harm the baby, and you don't want to do that. Or it could harm the mom, and you don't want to do that either. So you got to be careful what you give them. One of the things, and also, well, I'll just say it, you do not give a pregnant woman an ACE inhibitor or an angiotensin receptor blocker. So nothing with a pril and nothing with a sartan, okay? You just don't do it, okay? For whatever reason, it's dangerous. So what drugs do you give them? Well, the first ones that are indicated are going to be hydralazine and methyldopa. So there's 4, though, overall that were listed on here, and I found a silly way to remember them, okay? I put hydralazine, or they listed hydralazine, labetalol, methyldopa, and nifedipine. So the way that I imagine this, to remember that these are the drugs you give them, a pregnant woman with hypertension, is hydralazine. A hydra is like a snake thing with lots of heads. So I drew this pregnant woman over here with lots of heads, lots of snake heads coming off her. That's not hair, those are snake heads. So that's a hydra hair. So she has the hydra hair. Remember this picture? You can hopefully remember hydralazine because of the hydra hair. And also labetalol. Now whatever, that makes me think of labor. Okay, labetalol makes me think of labor. The pregnant lady is going into labor, so you give her labetalol. Okay, and you see you see here an olol. If it has the olol, you remember that is a beta blocker. Okay, labetalol is a beta blocker. Next here is methyldopa. Okay, so terrible way to remember this one, but this is what I did just to help me remember it. Is I drew this pregnant lady with the hydra hair who's going into labor. she has a bag of meth and dope. Okay, so there it is, her bag of meth and dope, her little bag. It's in her right hand. Now, the last thing was nifedipine. Okay, first part of here looks like knife, minus the weird K that doesn't belong there. So knifedipine. So I drew here with a knife. There it is. So she has a knife, a bag of meth and dope. She's going into labor, and she has weird hydra hair. And there it is. Remember, do not give her angiotensin converting enzyme or inhibitors or ARBs.